Hi, everyone. My name is Cheryl Cohen, and I'm with Arthritis Consumer Experts. And I could not be happier than to be joined in today's program by Dr. Ashley Sterrett. She's a rheumatologist practicing in Ottawa, Ontario, Canada. Welcome to the program.
Thank you so much for having me.
Yeah, it's really fantastic. This program, as you know, this particular episode, Dr. Sterrett, is really focused on talking to you and tapping into your expertise about really rheumatology workplace, and something that's important to our audience as well as to your colleagues, and that is the shortage of rheumatologists here in Canada, and I suspect probably other places in the world as well. So we have this, not that arthritis is an old person's disease, but we do have an aging population, and prevalence for some types of arthritis does go up. There is such a huge demand for people to get to people like you, people who are living with more severe types of arthritis, autoimmune arthritis, yet there's a shortage. So talk to us a little bit, Dr. Sterrett, about the shortage.
Yeah, I think there is a big age gap, and it's not unique to Canada. It's definitely worldwide. And every time I went to a meeting, either in the States or in Canada or in Europe, they bring it up. It's a known phenomenon. And I think part of it had to do potentially with 40 years ago, rheumatologists had limited options, but you knew what you were getting into. And the good options for treatments really didn't come about until about 20 years ago.
Yeah.
So you saw an increase in an interest in rheumatology around that time. And so, but there's a gap between the 30 to 40 years ago and then the 20 years and less, because it's not a huge, it's not a lucrative specialty. It's not super, at least it wasn't sexy until recently, now that there's all these interesting treatments and now that we can actually provide uh, benefits in terms of the ease the pain and somehow give quality of life options that we could not give before. Before it was just prednisone and disability.
Yeah,
And so
go
now,
home and rest and don't live a life, basically.
we'll put you in the hospital to where
Yeah.
you can basically seize up, and now we have a lot of options. But at the end of the day, there's definitely a need, and we are capturing some more interest. However, the training is fixed in terms of how many spots there are. For several years, and it wasn't unique to Canada, spots would be empty for rheumatology training programs. That's not the case now. They do tend to fill, but that still isn't, that it's still, like 1 to 2 spots per year per program, so forth. So it's not like we're making tons of rheumatologists. And so that aging workforce is now hitting us, that we knew was coming.
Yeah.
You mentioned the aging population. Again, you're right. It's not that is that comes with a guarantee of arthritis, but it does come with a lot of questions, at least, that need to be evaluated once or twice. And because there's so many more of a population than there are physicians, it just kind of creates an extra burden on the system.
Yeah, let me get to this. So you mentioned that the problem about shortage is not necessarily specific to Canada, that it is an issue around the world. Is there anything different about it in Eastern Ontario where you are practicing versus other parts of the country? Do you have special factors that are going into your issue of shortage?
I don't think so, honestly. I just know about Eastern Ontario because that's where I am. I actually was in Toronto for about a year and a half, and after I had to do a year of supervision, which was required for my license in Ontario from the States. And when I was done, I had to set up a practice, and there was no need. And so, I asked, where do I go? And a doctor in Toronto, a rheumatologist, said, well, Ottawa would love a rheumatologist. They're
Wow.
retiring like crazy. And that's kind of how I ended up here. But Ottawa's like a microcosm of what's going on everywhere. There's an older group of rheumatologists that have been practicing for 40 years, and then there's a new group that's maybe been out 2 to 5 years. I'm the most tenured at being out for 11 years, if you will. There's maybe one or two else. Otherwise, there's like a 30 to 40 year,
Yeah.
So it's sort of a microcosm of the bigger problem everywhere. And so that those people who've been practicing for 40 years, they're getting out, and there's not enough of the youngers to take over all of those patients. 10 years ago, you could come in, we could start you on a medicine, and it was fair to say, I'll see you in 6 months, because you were supposed to give someone 6 months on methotrexate and see them back, because you were supposed to give them that amount of time before you called it a failure. But now with treat to target guidelines, you're supposed to get someone in remission on rheumatoid in less than a year, or they're more likely not to achieve remission.
Yeah.
So now you have to try to get them, see them within 2 to 3 months, because you got to be making adjustments constantly.
Yeah.
Well, to see one patient every 2 to 3 months in that first year, which is totally reasonable, don't get me wrong, that's fair, that's what you need to do. That's a lot more frequent than twice a year. That's several visits for one patient. Now compound that by however many patients
Yeah.
you have, all of a sudden the number of patient appointment slots is cut by, I don't know, into a tenth of what you used to have. So the treat to target goals, which are appropriate, and that's what we need to have, it has definitely brought the disease management better. And
So,
we're
in other words, your therapeutics have advanced. How we use them has advanced, or not,
exactly
but we don't have the personnel to actually do it.
perfect.
Yeah.
Exactly.
Yeah. So turning to that, then answers. It's always great to poke around the problem. So I'm assuming that one of the things that can be done as we try to close the equity gap in the number of rheumatologists we're training in our medical schools across Canada, there are a couple of things, maybe more than a couple of things we can do right now
Yeah.
to sort of try to address a problem. What might those be, Dr. Sterrett?
And I don't know that I have the answers to this
Yeah.
either, but so one thing that British Columbia did is they allowed a nursing fee code. So if you have a nurse in your clinic, then you can add a fee code on that helps in the cost of that nurse.
Right.
And then different people will use it different ways, but the rheumatologist that I know out there uses a nurse to help screen and help with some of the admin, to help see follow-up patients, and then she's done it
Injections,
well.
right?
Yeah, it's as part of a model of care.
Yeah.
So that's one way. There's a physician assistant program, nurse practitioners, et cetera. But if there's a way to offset some of the costs of that up front, that would be something that I think Ontario could benefit from. Obviously, more rheumatologists would be great, but as I
Yeah.
said, like the number of training spots are relatively set,
Plus,
and that's
they
pretty
take
hard.
time. It's not like you can just flick a switch and create a rheumatologist.
Correct. So, of course, there's the medical school 4 years, internal medicine is 3 to 5 years, and then rheumatology is 2 to 3 years, depending upon if you do additional masters, et cetera.
Research training. Yeah.
Right. So
Yeah.
it's an extensive duration. So it's not like if you decide tomorrow, it's still many years from now. So, the idea of bringing a rheumatologist from another country that has already been trained but doesn't have to retrain. And several countries do fall under that category. Obviously, the US is one. They just have to be supervised for a year and then they get signed off. And there's nothing really wrong with that. I think that's actually a very good idea. And I'd be a big proponent of that. And so I think that would be a good option
Yeah.
to promote Canada to other countries, as long as, you don't mind the winter. There's nothing, I think Canada is amazing. Um, and so trying to put that into, and then obviously I'd really like to do something with MSK training for GPs. There's a program that got started in London, Ontario by one of the rheumatologists out there, Dr. Roker, and she's created like a little program that she does an extra training for family practice residents. I think it's an extra year, and they rotate with her. And I think that's a great idea.
Well, when you think about of the 6 million plus Canadians that have arthritis, 90% of them have a type that can be managed by a family physician if they have the right skills.
Well, and I was lamenting, a referral to a colleague, and they said, well, there's maybe 150 of us in Ontario, if even. I actually don't know how many there
I
are.
think there's about 200.
Okay, so let's say there's 200. I don't know that they're all seeing patients, but and there's something like 13,000 GPs. So the idea that, like I used to do little before pandemic, I would do educational talks, et cetera, to them to try to explain what is and what isn't inflammatory, et cetera. And it felt like, throwing salt in the wind, like we weren't getting anywhere. And they were like, well, how can you? There's one of you, and there's probably, five, 1,000 in Ottawa. I don't even know. So like there's no way to educate, one at a time. So maybe if we did like a program to try to at least help your area to understand what to recognize, what's
I
important,
think
what's not.
I think that's a great idea, and it's not dissimilar from what happens. The Arthritis Society in Ontario for years has
Yeah.
helped train up physiotherapists to have specialty arthritis training or knowledge.
Mhm.
And that has definitely moved the dial in terms of what quality, so not just quantity, but the quality of service that's delivered to patients like myself. And then I guess the other thing, Dr. Sterrett, that we could be looking at, it's not going away, is virtual care.
Yeah.
What role, while not every appointment can be done virtually, I think every patient and every physician recognizes where the limitations are. But a whole world has been opened up to both of us, really, to learn, well, what appointments can be had like this? And what efficiencies can we gain from that than in the in-person practice that we're holding, right? So I'm really excited about the opportunity for expanded or at least made permanent virtual care services. What can people just out in the public do to help support you or your own professionals, whether they're in rheumatology or outside of rheumatology?
I mean, the first thing obviously is what you're doing is
Is
getting the information out there. Yeah, I think there needs to be an awareness. I think patients are starting to feel it a bit. They're going to wait longer and longer to see specialists, particularly rheumatologists. I mean, right now, some patients in Ottawa don't want to drive from the east end to the west end, and that's not really going to be an option anymore. You can't pick where based on where you live.
Yeah,
We just don't have the capacity anymore for that. But I think I think recognizing there's a problem, right, is the
yeah,
first step. And then people smarter than me can come up with solutions. It's not unique to Ontario or East Ontario. It's going to be across Canada, but for me, it would be important to fix up the Ontario issue. So I think all the things we've brought up are a great
yeah,
solution. I don't think there's a one size fits all. We probably need models of care with nurses and physiotherapists, as well as more doctors, as well as GP extra training. It probably all needs to be done.
yeah,
But we're going to need some provincial support because I can only do so many things. There's only so many hours. Burnout is getting high. Some of my colleagues have already expressed to me that, and they're just new. They've just finished like within the last 3 years that they're like at the top. And
yeah.
so
That's not good. To be a newbie and talking about burnout is not good. Yeah,
well, they're worried because they can't see new arthritis within 6 to 8 weeks, then they can't follow them up within 2 months. Like they can't meet kind of these proposed treat to targets. They're like, well, they can't. They're already taken over too
and
much.
that you
So
have performance expectations for
yeah,
what you're doing in your job and
there's
what you're
been
supposed to be
suggestions we'll get
doing.
paid based on those
Yeah,
actually.
you've spoken a number of times about treat to target. That's your goal. You're in it to deliver life back to people like me, and there is a way of doing that.
Yeah.
And when because of the shortage of rheumatologists, the lack of supports that are in your office or being provided within the healthcare system by the province, that impacts on your ability to
To
actually
do my
get
job.
as well as I
Yeah.
can be, right?
Yeah.
And I think that's fundamental piece of information is going to be really important for our audience to hear. So I thank you for kind of reminding me of that. Oh yeah, our rheumatologists are out there doing a job and they want to do it really well.
Oh yeah. Yeah. You don't want that rheumatologist that didn't like, take care of people appropriately and then everybody's, has, deformities. You don't want to be that guy.
Exactly, exactly.
Because
Um,
the long-term impact is not, it's just horrible. Like it's not, nobody wants to not be able to treat people. And so there's a lot of added stress and pressure,
yeah,
personally to try to do everything appropriately, but you can only do so much. So
yeah.
it is really hard.
So I know you're very involved with the Ontario Rheumatology Association. You're very knowledgeable and obviously have really rolled up your sleeves to try to address this issue on behalf of your colleagues and their patients. And just so you know, I think just imparting this knowledge that you have today on our audience, we have all kinds of great advocacy tools that they can tap into. There is nothing stopping a member of the public writing to their local or provincial official, elected representative to say, hey, I'm waiting way too long to be seen by someone that I know has the expert expertise to deal with my health issue, and that's actually what the research says they
Yeah.
should be doing, and in the time frame they should be doing it.
Yeah.
So I think, if you push from your end and we push from our end as a grassroots, perhaps we can meet with success somewhere in the middle. But we
Yeah.
really can't thank you
I hope
enough for
so.
everything you're doing. We appreciate the time you've taken out of your busy day. I know it's into your evening now, and I thank you for giving up your time, your own personal time, to talk to us. And I hope that we both can come back to our various constituents and report positive news as we press forward on this shortage of rheumatologists issue.
I do too. I think I feel really blessed that the ORA, the Ontario Rheumatology Association, when I kind of sounded the alarm, immediately said, well, let's, start doing something about it. We've already had a couple of meetings in just a month. When I said, look, I just got 1,500 referrals and that's all I can take from one
Yeah.
person that just retired and we need help. But this is not a new issue. There's been a concern about this for at least 10 or 15 years. And so my hope is that there won't be another 10 or 15 years and nothing is still not
Yeah.
happened, because I'll be retiring in about 20. So,
Dr. Sterrett, and sometimes new voices, new energy can make a change. And I'm hopeful that's what will occur.
yeah.
We're in it with you. So we look forward to working together to make change. Thank you so much for your time. We really appreciate it. And
Thank you so much.
good luck moving forward. I'm sure we'll be seeing each other on a Zoom meeting sometime very soon.
Definitely. I hope so.
Okay, take care.
Thank you. Bye.